Hello everyone, so we are continuing with the invulnerable metabolisms. Investigation the we were doing hypoglycemia, investigation of the hypoglycemia screen at the time of hypoglycemia is required to identify an IAM endocrine cause, diabetes and endocrinology. Box 26.6. In the presence or absence of ketones should be specifically sought as their absence is an abnormal response on physical examination. In the presence of beta-megaly should be sought to identify glycogen storage diseases. Now, GST are a diverse group and can be divided into hepatic, muscular, and cardiac subgroups. The hepatic form is associated with hypoglycemia. GST type 1A exemplifies the hepatic form. It is due to deficiency of glucose 6-phosphatase leads to severe hypoglycemia because the inability to mobilize glucose from glycogen or utilize glucose from gluconeogenesis. The most common GST is GST5, also called myocardial disease. It is due to deficiency of myophosphatase. Patient corrections they have exercise intolerance relieved by stress, the second wind phenomenon. This reflects the ability of the muscle to switch to using other energy sources. Free fatty acids or free glucose in the blood they are at risk of exercise induced breakdown of muscle tissue, rhabdomyolysis, and its complication, particularly acute kidney injury, lysosomal storage disease. The solid lysosome is a recycling center of the cell and contains a number of enzymes. Deficiency of one of these enzymes results in an inability to break down a specific chemical, leading to its accumulation within the cell. This accumulation typically leads to sign of fecal storage, hepatosplenic belly, and of central nervous system involvement with developmental regression seizures of both. There are a number of groups of lysosomal storage diseases: mucopolysaccharidosis and sphingolipidosis, Fabry disease, diagnosis initially based on urinary GAGs and oligosaccharide screening, followed by blood testing of the lysosomal enzyme and genetic testing. The case history: glycogen, 4-month-old boy with a normal neonatal past medical history, presents with a 1A history of cough and fever. Now, the cough and fever has not fed for 12 hours and has produced wet nappies. On examination, he has cherubic face. The clinical features are moderately severe bronchiolitis. He has a tendency to soft and large liver. His blood glucose is 1.8. On investigation of his hypoglycemia is found to have a lactic acidosis, serum is milky, and triglycerides are raised. The nurses note that he becomes sweaty and irritable prior to feeds. Glucose monitoring demonstrates pre-feed hypoglycemia feeds are more than 2.5 hours apart. GC type 1A of diagnosed is diagnosed and confirmed on mutation analysis. He's commenced a too early daytime feed and continues overnight nasogastric feed. Features of the glycogen storage disorder by GST type 1 often presents when illness prevents feeding or when an infant feed frequency is reduced. The hepatomegaly can be easily missed as it has a soft consistency. Lactase is raised because it acts as an alternative fuel. Mucopolysaccharides MPS are the more commonly seen lysosomal disorders. There is a defective breakdown of GAGs. They are progressive multisystem disorder, which may affect the neurological, ocular, cardiac, and skeletal systems. Different forms of MPS have highly variable clinical features. The characteristics of 5 of the varieties are shown in table. As seen from the table, the majority presents with growth fattening, developmental delay, dysmorphism, and patisomal in the first 6 to 12 months. Dysmorphism is typically a coarsening of the facial features and prominent forehead due to frontal bossing. Once the diagnosis is suspected, initial test is measuring the excretion in the urine of the major storage substances, the GAGs. This is followed by lysosomal enzyme testing and genetic density treatment supportive according to the child's need, and a number of the conditions have enzyme replacement therapies available. Successful enzyme replacement by hematopoietic stem cell transplantation has been performed for MPS type 1, but it cannot reverse and establish neurological abnormality, has a minimal effect on the skeletal component. Mitochondrial disease, the Krebs cycle, also known as tricarboxylic acid cycle, is found in all cells except red blood cells, which lacks mitochondria. The primary function of this system is the production of ATP and from the process of oxidative phosphorylation. Mitochondrial disorders are those directly resulting from deficits in early production of oxidative phosphorylation and therefore affects those organs with the greatest energy demands: brain, heart, kidney, retina, skeletal muscles. Clinical presentation is very varied. Some clinical syndromes are recognized. Investigation is difficult and often only symptomatic treatment is possible. Mitochondrial disease should be considered when there is multisystem disease, elevated lactate through differential diagnosis wide, and it is not always present. MRI brain scan showing characteristic features. So these are mitochondrial disorders. Morph micron epilepsy with ragged red fibers, 5 to 15 years may last. Mitochondrial encephalopathy, lactic acidosis, stroke-like episodes, myopathy, migraine, vomiting, seizures, visual and hearing disturbances, 5 to 15 years. Outbursts, intractable seizures, and light liver involvement, early childhood. And okay, this was metabolic acidosis. Lipid storage diseases. Lipid storage diseases are a group of IM in which enzyme deficiency causes lipid accumulation in cells and tissues. This excessive storage of fats can cause permanent cellular and tissue damage affecting the brain, nervous system, liver, spleen, and bone marrow. The most common lipid storage disorder is Gaucher. Disorders of lipid metabolism. The most common reason for raised cholesterol in childhood is obesity. However, familial hypercholesterolemia is the most common inherited disorder of lipid metabolism. The majority of children with the familial disease form are detected because a parent has presented with an acute myocardial infarction. However, in the UK, with the implementation of the National Familial Hypercholesterolemia Screening Program of cascade testing of biological relatives of people with FH, there is likely to be an increase in number of children diagnosed. Now, the mucopolysaccharide doses, untreated Hurler syndrome showing the Cushing's facies and skeletal dysplasia, dominance of the lower spine is caused Gibbs. Clinical features of muco, MPS eyes, cornea clouding, skin, thickened skin, coarse facies, heart, valvular lesions, cardiomyopathy, neurology, developmental regression, skeletal thickened skull, broad ribs, claw hand, thoracic kyphosis, lumbar lordosis, other hepatosplenomegaly, carpal tunnel syndrome, conductive deafness, umbilical and inguinal hernias, and type of MPS1, Hurler, MPS2, Hunter. Hurler has autosomal recessive, and Hunter has excellent cornea environment and heart environment and brain environment, skeletal environment. And Hunter has excellent and cornea environment. There's no cornea environment, it's heart, brain, and skeletal environment. MPS3 is Sanfilippo, autosomal recessive, and Morco and Mortex, Lemmy Oller, autosomal recessive. And there's cornea environment at MP6, and heart environment, there's no brain environment MP6, and no in MPS4, but there's cornea environment plus minus, and no heart environment and MPS3, but the brain and skeletal environment is there. A few children with homozygous familial hypercholesterolemia may be the index case. They typically present before 5 years of age to dermatologists with lipid deposits. These deposits classically occur in the nasal cleft and extensor surfaces of the elbows. Treatment of heterozygosis is with the use of a low-fat diet from the age of 80 as a statin. In homozygous patients, the risk of myocardial infarction and stroke in the early teenage years is extremely high. Treatments started the low-fat diet, a statin, and ezetimibe, which lowers cholesterol if there is a poor response to treatment in homozygous patients. Other treatment options include lipid apheresis or liver transplantation. Treatment is PCSK9 inhibitors are being increasingly used for children with homozygous form. Normally, low lipid levels can also be an indicator of metabolic disease, A beta lipoproteinemia. So, microbial case history: Amy is 80 years old, presents with a 3-day history of an upper respiratory tract infection, the sudden onset of seizures, and encephalopathy. She was admitted to pediatric intensive care unit, and investigation demonstrated rhinovirus in nasal pharyngeal aspirate and a raised lactate of 9, which failed to normalize one seizures control years of pain. An MRI head scan showed basal ganglia calcification in the area of infarction, not confined to vascular territories. On history taking, there was a significant family history. Okay, significant family history. Amy's presentation and family history is the same mitochondrial disease, especially MELAS. Genetic mutation analysis confirmed MELAS. Amy recovered from this episode but died 2 years later from recurrent stroke-like episodes and lactic acid. Features of mitochondrial disease are there may be a marked intrafamilial variation. The family history and drawing family tree are helpful. Infection is often a trigger for acute decompensation. Died age 55 years from recurrent stroke-like episodes. Female, and then sensory neural hearing loss. This was the family tree consisting of mitochondrial disease. Mitochondria are the product of a nuclear and mitochondrial genome. Mitochondrial genome DNA is inherited exclusively from the mother. So they're female, sensory unit, ATS, raised like days, seizures, and mild learning difficulties. And Sophie, 18 years, and she is well. The proportion of copies affected by mitochondrial mutation, the severity of the mutation, and the tissue response determines the severity of the clinical phenotype. Here, Amy has LAS, and she has high proportion of mitochondrial DNA, whereas others in the family with lower levels only suffer from type 1 diabetes, sensory hearing loss, and raised lactates. So summary of the features: Fabry disease, enzyme defect is alpha galactosidase, only X-linked lipid storage disorders, males present in childhood with recurrent acute pain. This is for lipid storage disorders. And recurrent acute pain, paresthesias in limbs, diminished sweating, and angiokeratomas, and normal intelligence. Females have 70% is say symptomatic presentation tends to be from age 15 onwards. Enzyme replacement therapy, washers, beta glucosidase occurs in 1 in 5 learner Ashkenazi Jews, and chronic childhood forms, carry bone marrow suppression, bone involvement, normal IQs, connecting may alleviate hypersplenism. Enzyme replacement therapy, acute infantile forms, carry neurological degeneration with seizures, carrier detection, and prenatal diagnosis are possible. Niemann-Pick disease, cholesterol trafficking disorder, infantile neonatal liver disease with hepatosplenomegaly usually improves by maybe fatal juvenile, age 3 to 15 years with progressive ataxia, language delay, hepatosplenomegaly, vertical supranuclear gaze palsy, cherry red spot 50%, and at 7 years to adulthood, adult ataxia, dementia, psychiatric illness, treatment with substrate reduction therapy, Ullmann syndrome, lysosomal acid lipase, neonatal presentation, severe growth faltering, steatorrhea, massive patosphilum X-ray shows adrenal calcification facial within first year, usually by replacement therapy. Severe skin xanthomas in the child, it is secondary to liver failure, and the condition resolved within weeks of liver transplantation. Summary: in one error are individually rare but collectively non-uncommon. Neonatal blood spot screening, the 3 tests allows the diagnosis of 6 unborn in one error of presentation may be at any age with serious unseen illness, hepatomegaly, sphenomegaly, cardiac failure, drowsiness, seizures, dysmorphic features, developmental regression, sudden and unexpected death of infancy. Should also be considered if there is hypoglycemia, marked metabolic acidosis, high iron gag, or respiratory alveolar of unknown cause. Hyperammonemia is a time-critical medical emergency. Rapid diagnosis is essential to allow early treatment to reduce morbidity and mortality. Investigations and management are complex and specialized. Consult a specialist metabolic center early. Affected children can deteriorate rapidly during intercurrent illness and may have an advisory emergency management plan. So this is all for. Next we have musculoskeletal. We'll start with this. And thank you very much.